Hello, everyone, again. So as my slides are coming up, it's great to see that we still have a lot of attendees online and some here in person. I'm going to be speaking about procedural sedation and analgesia, which may be different depending upon where you're located in terms of what your scope of practice is, what your agents are that are available. But I'm going to walk you through a little bit of how I approach this topic, and hopefully we can go through some cases in this discussion as well. They're going to pull my slides up, right? Or should I do it? I have control. This is much better. Yes, I like control. Okay. So here we go, procedural sedation in the emergency department. So again, no conflicts of interest. My hope today is to talk a little bit about analgesia, mostly about sedation, but we'll define those two terms. Then we'll move on to talk about the mechanisms of action, pharmacokinetics, and some of the side effects of some common agents. I think that it's really important, and sometimes bringing back some of our pharmacology lessons actually are something that I can apply both in rapid sequence intubation as well as in sedation. So some of those lessons that you're learning as students really can be applicable later on. And then describe approaches to choosing the appropriate sedations for the appropriate procedures. Lost control now. Let's see. I think he took control of that. Oh. Okay, so starting out with some definitions, and I think distinguishing between sedation and some of the other effects that we're looking for from these agents. Sedation is a reduction in activity, anxiety, stress, irritability, excitement. But then we have some other attributes that we can have in many of these medications and some attributes that we wouldn't have in some of these medications. So analgesia is a key one in the emergency department, that there are certain procedures that we would not need analgesia for, maybe something like an MRI. And then there's other procedures which absolutely it's really helpful and appropriate for that patient to sedate them together with an analgesic effect for something like a fracture reduction. So analgesia is the relief of pain or the alteration of the perception of stimuli. And then we have some other effects that we see with these agents, which we'll talk about later. One is amnesia, and I think a very helpful effect of some of these agents are actually both a retrograde and anterograde amnestic effect, so taking away some of the memories that they might have of some of the things that we did to them, maybe even putting in the IV for sedation. Anxiolysis, I do wish that we could give some of the anxiolytic effect to the parent, but unfortunately we cannot do that, but assuring the parent that we can address some of their child's fear and distress, and then a hypnotic related to drowsiness or sleepiness. So what are our goals? Again, it's to improve both the psychological and physical outcomes, but I think the psychological comfort, decreasing their fear and anxiety and causing the amnesia can be very helpful. From a long-term perspective, even if they don't remember, we know that by appropriately treating pain, we can decrease both adverse medical outcomes as well as things like post-traumatic stress disorder that kids can have from some of these events. Lose control again. We oftentimes, for the goals of our procedures, want to facilitate the intervention. Sometimes we want the child to do nothing, like for an MRI, and sometimes we'll want that child to be relaxed to do something like reduce their fracture. Last effect that we can have from some of these agents is reducing metabolic demand. I would say that probably comes into the cases where this is a patient that is intubated, not really a procedural sedation, but when we do have patients that are requiring sedation and maybe want to decrease their metabolic demand, probably more of a patient that would be in the ICU or another location. So the levels of sedation, looking at this traffic light sort of tilted sideways here, I think are really important to think about when you're thinking about selecting an agent, but as importantly, or if not more importantly, think about when you're doing a consent or preparing the room. So this ranges from minimal to moderate to deep sedation, and where we want to be in the emergency department is within that green or yellow, but we need to be prepared to be in deep sedation or even for general anesthesia. So being prepared for one level up for the procedure and being prepared to manage the airway for that patient that's one level up. So our goal would be here for most of the patients that we're going to talk about as we go through some cases, either mild, moderate, or deep, but recognizing that any of those patients could move down to general anesthesia and might need an escalation in something like an airway. I tend to like AVPU for both trauma as well as sedation. This is something that you can use across the age continuum. Some of us will talk about tickles for the younger infants, looking at their tone, interactivity, consolability. But AVPU, I feel like, works pretty well for that overall assessment of that child. What is their level of sedation? There are some scales for this, but are they alert? Are they verbal and talking to you? Are they responding to painful procedures, or are they unresponsive? And depending upon where you want to get them to, the agent might be quite different. So for something like an IV placement, we probably really are only aiming for them to get up to the painful. For something like a reduction, we might end up targeting unresponsiveness. So again, that's the levels of sedation. Minimal, to go back to that green light here, would be things that we often can do in the emergency department without the need for monitoring and invasive procedural events. So these might be things like giving a medication for a laceration repair. I'm not sure how often you're using intranasal medications here. It's become really commonplace for us to use intranasal Versed, and this is a really, I think, almost gone so far that it's hard for me to do a suture repair without giving the patient intranasal Versed, because it's part of our protocol. And sometimes the family is saying, do I really need that? And we'll hold off on it. But the patient should be responding normally and be in that alert category of AVPU. If we're moving to moderate, this is where you're going to get that drug-induced depression of consciousness. They should still maintain their airway reflex, and they really should respond when you touch or stimulate them. So this is what we sometimes would call light sedation. They should be responsive to, you shouting or yelling, and respond to some tactile stimuli without doing a sternal rub. The deep sedation, really, this is someone that would not purposely move, that might need a sternal rub. They're not going to be under general anesthesia, and they may respond to that severe painful event, but really they should have most of their airway reflexes intact. And it's when we're moving to general anesthesia where they would lose their airway reflexes. So before you sedate, just like before you take care of the trauma patient, as I mentioned earlier, preparation is really key. And you want to make a decision of whether or not this patient is safe to sedate. I think that some of the topics, and we'll come back to NPO status, which is really something that we, I think, overly focus on, really receive a lot of attention. Some of these other aspects of risk assessment sometimes don't receive the attention they deserve. So I'm hoping that one of the key takeaways from this talk will be risk stratifying these patients and looking at why we need to collect some of this information when we consent for sedation, but that this isn't just consent, it's actually a risk assessment to decide, is this patient safe from a provider standpoint to do this procedure in the emergency department. So weight, your exam, you may do an ASA score, get the history, you may look at when they've been NPO from, you then will use that information only if that information suggests that they're safe to sedate, would you move on to get consent. And based on that discussion with the subspecialist, you might actually decide this procedure is not worthy of an emergency department sedation because of the duration. And I think that's somewhere where I really struggle to say what my cutoff is. I would say a half hour is usually what I'm aiming for. If they get up to 45 minutes to an hour, it is a difficult conversation, but needing to move that procedure to the operating room, just from the fact that the risk of sedation goes up quite dramatically as you increase that duration of time. It also pulls you away from the rest of the ED. So these are my red flags. So not in the ED. These are the patients that I would suggest avoiding. Less than 12 months. This is a population we don't as often need to sedate. I think I would just think very closely about what resources and services you have for those patients. I wouldn't say that's a hard and fast rule. Certainly a population you could sedate, probably the weakest of the ones I'll mention. Obesity is one that I think that people are a little bit cavalier about, in our department at least, where these patients with over the 95th percentile BMI really do have an evidence that supports that they're much higher risk for complications. History of snoring or sleep apnea and difficult airway craniofacial abnormalities, I'd say is probably one that we do respect and that many of us are aware of in our emergency department and health system. We now have a difficult airway flag that comes up in EPIC. So sometimes this is intuitive, you see it from the outside. Sometimes in a chronic patient, this is someone that's been hospitalized a few times and maybe been to difficult airway in the past. You're going to look, listen, feel. We have the Lemon score. We have other techniques, but really looking at that child's face, I think if you look at this child with micrognathia and Pierre-Robin here, it's pretty clear to me that that would be a difficult to intubate child. If you ask them to open their mouth, and this is an obese child, and you're seeing what you see in items 3 or 4, or in case 3 or 4 there for the Malampati, both of those should really heighten your concern, because if you see on the right side of the scale there, your POGO score, percent of glottic opening score that you would expect to see in that Malampati class 3 or class 4 is going to be very poor, and it's going to be a difficult airway. So looking at the ASA classification, again, using this green, yellow, red, I would say that in the ED, we're going to aim for that green or yellow population. I think one of the populations that causes some consternation for outpatient anesthesia in the US, and I think we need to think about in the emergency department, is active wheezing or active URI symptoms. These are patients that I struggle with to decide whether or not they're safe to sedate. I think we often do sedate them, but this patient that has a minimal wheeze that is right between that level 2 and 3, I think is a really difficult patient to make that decision in. I can tell you that our anesthesiologist would send that patient home and not do the procedure on them. This also depends on the procedure itself. If this is something like an orthopedic procedure that could be done in the morning or at a later date, that patient may be better served by deferring the sedation. As we move into class 3, 4, 5, and these are patients with things like Down syndrome, patients with things like complex congenital heart disease, these discussions, I think, are things that need to happen probably more often in many of our departments, just risk stratifying those patients. While it's common to us to see that population is not necessarily the common type of patients that's included in most of our sedation research and studies. So MPO is a old habit that's hard to crack. We talked about de-implementation science a little bit in the last session, and I'd just like to reiterate that when something has been practiced and is in our guidelines and is often in our policies, and you even hear horror stories about, it's very hard to take that practice away. So when we look at MPO status, there's no association of adverse events in the people that break the rules and provide sedation in that 2 to 4 hour mark compared to those that follow the rules in the 4 to 6+ hour mark. So I think a 2-hour cutoff is something that many of us need to consider. Certainly using common sense, if someone's eating a Big Mac as you're coming in because their parents brought them that because they hadn't eaten since this morning, certainly someone that you want to consider deferring. And if that procedure is not as time sensitive, considering deferring. Looking at the ASA AAP guidelines that are listed here, I would argue that these probably could use some updating and may not be consistent with the current best evidence. But these are existing guidelines, which causes a challenge for many of us because it is difficult to deviate from the guidelines. And again, in some of our institutions, this is a policy where the nurses will say, you know, this patient's not been MPO for 4 hours. I would say that giving a patient, ice chips or water is quite different than that patient having French fries or a hamburger. And again, 30 minutes is quite different than 2 minutes, which is quite different than 2 hours. So my, comment on MPO is that the evidence really does not support where the guidelines are. And we want to think about this both within the research evidence as well as within our clinical practice of our institution, because we often need to adhere to, particularly if it's a policy statement. We need to prepare our teams. So our teams should be aware of not only the patient's weight, but what equipment they might need. And I would say for the moderate and deeper sedations or general anesthesia, this would be a full set of airway equipment and a full setup for that. The staffing is something that I have been very happy to see a change, at least in the US and in the institutions I've worked in over time, where the proceduralist and the sedation provider are 2 independent practitioners. Unfortunately, when that person is concurrently trying to do both tasks, that can be quite problematic. And there are cases where, a deterioration in that patient is missed for a period of time. And ensuring that the proceduralist is prepared for the next level up. So it's not really helpful to have a proceduralist in the room. A sedation doctor in the room that does not know how to manage an airway should that happen, even though that is an uncommon event. Preparing our equipment, I like this pneumatic soap me. So getting out your suction, that's something that I often forget. I think the oxygen, your backup airway equipment, so the nasopharyngeal or oropharyngeal airway, the laryngeal mask airway that are age appropriate in size. The medications usually do come into the room. Different individuals have a different threshold related to when they would bring in a medication like a paralytic, and we'll come back to that with ketamine. I would say that reversal agents are potentially available within the department is my philosophy, that that's reasonable, don't necessarily need to be in the room with the patient. And then from a monitoring and equipment standpoint, we have a checklist, and we're very fortunate that our nursing staff is very diligent about getting these resources set up, all the way down to end-tidal carbon dioxide monitoring, but making sure that you do have those backup supplies like the intubation equipment, again, available, not necessarily in the room, but accessible should you have a untoward event. I think preparing the patient and the parent concurrently is really important here. We do have child life staff. I'm not sure, do we have, in the kingdom, do you have child life staff as well, or is that a familiar tone? Okay, so I'll come back to that a little bit later, but this is a group of master's trained professionals that have degrees in child development and are very, very helpful in helping the child to understand what the procedure is and what the sedation will entail, as well as the parent. So they, you want to decrease their fear, stress, and anxiety. One of the things that Child Life is very helpful with is bringing distractions, games, turning down the lights, playing music, things of that nature, and really encouraging us to have the family present, at least for the induction of the procedure, and sometimes even if after the procedure starts. I would say I've learned the lesson the hard way, that you want to always have the family sit down. I've had 3 or 4 people that have fallen and either ripped the sink off the wall or knocked their child off the bed because the parent passed out during the procedure. So I would argue you should always have the parent sit down. So just to go through some patient cases. So we have a 4-year-old male, they fell at the playground. They have a very displaced, an angulated fracture of the radius and ulna. What would your agent of choice be in this case? So I'll give some options here. Okay, so I see a ketamine. That's a good choice. I like ketamine for this patient, and there's a variety of reasons why, and we'll come back to some of these other agents later on, but the mechanism of ketamine as a dissociative, amnestic, and analgesic effect, I really couldn't think of a better recipe than that for this condition, which is a very common condition that we see. And the other benefit is the pharmacokinetics and pharmacodynamics fit really nicely. We want about 15 to 20 minutes, and we get just about that with our ketamine, and we sometimes can give an extra dose and don't have it as much, while we have a slight increased risk of side effects. Once we get up to 4 or 5 mg per kg, we do have the ability to repeat dosing without as much concern as other agents. It also has some hypertension and tachycardia effects just to be aware of, not something that usually causes much harm in our patients, but that sympathomimetic effect with the sedation is just something to be aware of. I think also for the family, making them aware of both the flushing and the nystagmus, because that's something that without warning the parent can be quite disconcerting to them. I am a little bit more old-fashioned in terms of ketamine and a little bit more nervous about the use of intramuscular ketamine. It's just the way that I was trained, so we tend to not use intramuscular, intranasal in my department. We tend to start with intravenous in that 1 to 1.5 mg per kg. One of the other downsides of intramuscular ketamine, it's very interesting, in a US study, the nurses expressed some resistance because the patients were having a much longer duration of stay in the emergency department to recovery. So while it seems easier not to have an IV, it actually might prolong the stay of that patient and the recovery of that patient. So I typically go with a intravenous dose, and recognizing that as we get to 5 mg per kg and above, that really is getting into general anesthesia. And we'll see, I'm not sure if your cardiac anesthetist here like ketamine, but for certain procedures, our cardiac team is using that at the 5 mg per kg range. There's a number of different adverse events, and I think one of the ones that I really try to impress upon our learners to talk about is recovery agitation and sleep issues. I think this is something that's not as brought up as commonly. The recovery agitation, when and if it does happen, up to 10%. Really nice to warn the parents that your child might wake up to be a beast and act like they've never acted before, and letting them know that's a risk, and being prepared for that. I think some of the sleep things later on, just warning them of that. The emesis is also quite a common thing. So having Zofran ready, not necessarily something you need to give to start off, but letting the parent know about that. And it increases quite significantly with a higher dose, and again with the intramuscular, so something that might potentiate the vomiting. The airway adverse events are clumped, unfortunately, into some earlier studies as airway-associated adverse events, and included things that I care about, like laryngospasm, as well as things that I don't care about, like transient apnea. So I think if I need to do something to that patient, which might involve moving their head, moving the oxygen so that it's still on them, I care. If it's something that I need to do something like push on Larson's notch, which we'll talk about, or intubate that patient, I really care. So, you know, for the laryngospasm, depending upon the study, it can be 1 in thousands to 1 in 10,000s. And I think something to be aware of. And certainly, I know when a nurse has experienced it before, because typically that nurse will be bringing in the succinylcholine into the room. I think you never forget that. In the younger kids, so certainly that less than a year, more likely to see some of the adverse event, but really the dosing related. And this is why, as we get up to that hour-long procedure, 4 to 5 mg per kg, I need to go see my other patients, but I also let the orthopedic surgeons know they need to call their attending and do this in the OR because of the higher risk of adverse events. Co-medications with atropine as an anticholinergic and with a benzodiazepine as a relaxant are two things that I was taught. This atropine versus ketamine was the old school 0.01, 0.1, and 1 mg per kg. The evidence really does not support that. I would say that the selected populations where we are using benzodiazepines is a child that maybe is very fearful of an IV, giving them some intranasal benzodiazepines. And if a child has a very difficult reduction, sometimes giving some benzodiazepines will help in terms of getting them basically back into anatomic position. So my practice is actually not to use either of those agents based on the increased risk of adverse events, other than in selected situations. The intraocular pressure is still correct, and I think something to consider that could be a harmful side effect. I would say it's not something that we are typically doing anything that involves the globe itself in the ED. That's typically going to the OR in our institution. And then intracranial pressure, we talked about earlier this morning, not something that I would change my management for. So this is, I think, a nice, trivia piece. I'm not sure if I have personally experienced use of Larson's point to be effective, but it is something that seems a little bit voodoo, so I think is always worth talking about. So the first thing you're going to do with laryngospasm is call for help. The next thing you're going to do is have them call for help again and make sure that people are on their way. The next thing you're going to do is make sure you heard the alert over the loudspeaker calling for anesthesia. And then you could start, as someone's repositioning the airway, as someone is doing all these other things in the room. And then if you really are bagging, can't get anything through, you could start to think about putting this painful inward and anterior pressure on Larson's point bilaterally. So a little bit like the Vulcan death grip from Star Trek. But there is some very weak evidence that might actually mitigate the laryngospasm. I would say that if you're at the point where the laryngospasm is not mitigated with bag valve mask and repositioning, this is someone that, ideally someone is running to get the paralytic while you're trying to remember or Google Larson's point. If no response, you're going to deepen that sedation and paralyze, as I mentioned, and then consider intubating. Another, pearl that is out there is a chest thrust maneuver that by putting a very deep pressure on the chest and causing that positive intrathoracic pressure to go upwards, that might actually open the vocal cords and allow tube passage if you don't have a paralytic present and ready to administer. This is a nightmare situation. I would say that the few times that I've had laryngospasm, I'm very fortunate. I don't know if this is wood, but knocking on something, that this is someone that you can bag through and reposition. So ketamine, I would say, is really our drug of choice for that patient with an orthopedic injury, and what we're going to go through with quite commonly. There hasn't been an emergence, and I think we're on the downslope of this, fortunately, of ketofol and the use of propofol and ketamine together. And the reviews that we have done, there has not really been any improvement, and there are potentially some additional side effects. The hope was that this would reduce sedation time, potentially reduce the dose of ketamine that you need to be giving. does sound nice. It's a neat word to say ketofol, but it's not something that has become within my practice. The mechanism of propofol as an agent is the activation of GABA. So the important thing to recognize here is it does not have much analgesia effect. So for procedures that require analgesia as well as sedation, this is not an effective agent. The one use case that I can think about in our department that we are using this quite commonly with is for prolonged imaging, something like an MRI procedure. The pharmacokinetics and dynamics of propofol, the really great thing is the quick on, quick off. So the fact that you can have this agent turned off and stop functioning within 60 to 90 seconds is really phenomenal, particularly if you have someone with like a neuro injury where you need to reassess their neurologic exam. And as we get up from that, 50 going up to 75 to 150, that's where you're starting to get into the general anesthesia effect. And the great thing is recovery is very rapid. So while we do see pretty profound hypotension in our pediatric patients with propofol, that hypotension is short-lived and something that my intensivists get me a little bit nervous with because they're pretty generous with pushing it and they'll see the blood pressure come down. And my wife's a pediatric oncologist and does a lot of bone marrows. And all the time she's saying that they'll see the pressure come down. They don't even worry about it. They just stop pushing the propofol as much. Other effects that you can see other than the hypotension, which is probably the most common thing we see in pediatrics, the respiratory depression, which is expected, pain or burning at the infusion site, which can be relieved by administering slower or some lidocaine. And then there is a black box warning, and I think depending upon your duration of sedation, this is really important, that if you are looking at sedation over greater than 24 hours, this propofol infusion syndrome in pediatrics is a real entity, leads to a refractory and irreversible metabolic acidosis. So certainly for that prolonged sedation, if you are thinking about, I would say greater than 24 hours is the black box, but I would say not something I'd want to be using if I was waiting for a transport 4 or 6 hours. I'd want to switch that agent over. So ketofol, as I mentioned, little significant superiority. You do get the combined effects of both medications, but because the child can tolerate the hypertension pretty well, I don't think that there's as much of a benefit to using them both concurrently. So another case, a much more common case, as I mentioned before, a fall with a laceration. I heard that oftentimes you're needing to have plastic surgeons come here. So in some of the departments at the military hospital, I was hearing this, that you might need to get the plastic surgeon to come down even for a minor facial laceration. So if you have this patient with a facial laceration, what type of agent would you use? The parents saying, I want something for my child. You can't do surgery on them without, someone mentioned surgeon, so you can't do surgery on them without any medicines. 2, so child life, okay. So child life can be very effective. Unfortunately, it sounds like you don't have that here, but we can do some of the child life procedures ourselves, or nothing. So nothing, I call this brutane, and I think depending upon how we do nothing, there's a big difference. So if we use a little bit of those child life techniques, blow bubbles, turn on some music, do some distraction, that's very different than using, on the right side here, what we used to use quite commonly when I was training, a papoose board, where you're basically strapping the patient down, not letting them move at all, shining a bright light at them, having a lot of people yell, doesn't work so well, causes some PTSD. The non-pharmacologic methods that are very effective, really good explanations by the staff. Lighting is something that I think is much easier to do than we respect. So turning the rest of the lights off in the room, just using the procedural light, decreasing the noise level, sometimes turning the temperature either up or down to get the room at a comfortable temperature. And iPhones have completely changed this. So it used to be that we need to try to find a TV or find a channel on TV with a cartoon. Now every parent has the iPhone with the show that the child likes. And I think that you can really get some of that audio and visual distraction. And the younger infants, sweeties, it does have an opioid-like effect, and certainly something that has become our standard for even a catheterization in young infants, a urine catheterization. It has demonstrated analgesic properties up to probably about 6 months, sweeties. So for this patient, child life and benzodiazepines are probably what would happen in my department. I had mentioned benzodiazepines before and child life before. So just to quickly mention what child life is, when I was leaving for this meeting, I walked past the sign and was actually thinking, do they have child life in Saudi Arabia? And I was astounding to see that our hospital is celebrating its 56th year of child life in the hospital. So it's been around for longer than I had thought. It's a master's degree. They actually have 600 clinical hours of internship, so quite a lot of onboarding experience. And they learn about both child development, distraction techniques, education techniques, and depending upon the study, up to 20% of patients, you can obviate the need for the higher level of sedation. It is costly. This is a group of individuals that you need to have around 24/7. I would say in our children's hospitals, all it takes is a couple of angry parents writing letters. We have something called patient satisfaction surveys. So when parents report that the staff was using butane, that leads to actually more child life funding, I would say. The mechanism of benzodiazepines are inhibitory. Really, the clinical effect here is an anxiolytic sedative and does not have analgesic effects. I find that letting the parents know about the amnestic effect, again, is really important here, because when we're getting prepared for the procedure, even giving the intranasal and the child freaks out, most of those children will wake up and say, when are you going to start the procedure? And they don't look at you pissed off or upset or looking at you like you just hurt them. So I think it is evidence, and I'm comfortable telling the parents, while some of the things we'll be doing when we are trying to get your child calm might be looking like they're really hurting them, you might actually be able to tell them that the child's not going to remember that. We have an expert here in Dr. Shah in seizure use of midazolam, but midazolam from an IV or intramuscular route is effective and can have a max effect in somewhere between 5 minutes for IV, a little bit longer for IM. But one of the benefits that we have with our atomizers is that giving it intranasally, it's pretty quick on. We do need to wait that 5 minutes. I've had a number of residents where I come into the room and I find that the midazolam is just starting to kick in after they finish the procedure. So you probably want to make sure that you have the 5 minutes. Another time child life is really helpful. Well, they'll usually come grab me and say, hey, someone's in the room about to start the procedure. The nurse just gave them midazolam. So it needs about 5 minutes. Quick off, so about 10 minutes to turn off, as opposed to the oral, which will be a little bit longer to turn on and a little bit longer to turn off, but oral can work as well. So in this case, we would use intranasal midazolam in my department. Very uncommon, you would need the reversal agent. I think it is important to let parents know again about the paradoxical reaction, particularly in the younger infants, less than 2, or children with developmental delay. Respiratory depression, very uncommon. More often, what we'll see is mild transient respiratory depression and not something that requires any type of intervention. So nitrous oxide is an agent that unfortunately we don't have in my department. I know that some of my colleagues have this in their department. Do you guys have nitrous oxide in the department here? So there's an expense to some of the systems to reclaim and make this from the atmosphere and make this safe. It's GABA inhibition. It has very nice sedative, amnestic, and analgesic effects, although those are mild. So very helpful for something like a dental procedure. That's why many dentist offices have this. If you do have it available, it's very helpful for other things like IV placement or short minor procedures. The pharmacology, super fast onset. So now we're talking about 30 seconds. It's a good adjunctive, as again, if you're putting that IV in. You need that equipment both for the administration as well as the reclamation of it. And the adverse effects are vomiting, dysphoria. You can have some transient respiratory depression, and there are some contraindications related to the fact that this is an inhaled agent listed there. So now case 3, we have a 26-month-old female. She fell, she's got a big laceration and expanding hematoma. She fell from 15 feet. So a number of us are involved in PCAR, and she has a greater than 2 centimeter hematoma on the parietal area of her scalp. So you're pretty worried about her. She's now vomited a few times, isn't acting normally. So you are deciding that you might need to do something. Or you might not need to do something. So you could start with the PCAR decision rule, and if that does lead you to get a CT, that doesn't always obviate the need for sedation. So even that child that's screaming, yelling, my experience has been with the appropriate CT technician and doing this in a way that is child friendly and maybe again channeling some of that child life, that the CT itself is usually less than a minute, but the preparation for the procedure and making sure that child is in a calm environment, potentially has the parent coming in there with them, helping them calm down, is something that can set you up for success. So the safest thing is nothing at all. I would say that we want to avoid repeating the radiation. So that child that's continuing to go bananas every time they start to try the CT scout is certainly a child that you would consider another agent. Propofol can be an effective agent. A benzodiazepine can be an effective agent. Here, we're not needing an analgesic effect, but involvement of the parent, I think, has gone a long way. In our center, we are starting to use some virtual reality goggles, which can help quite a bit as well, and they can keep those on during some procedures, but really that might affect your head CT imaging here, so probably using other techniques for distraction like video. So, we think that the child sees that the child's going to be calm and cooperative. Sometimes the child will look like that, but I want to remind us that oftentimes we look like the devil to the child, and we might really look like a monster or a devil and be scaring that child. And changing that frame can really help us in terms of the success with our CT. So etomidate, as I mentioned before, is a sedative, anxiolytic, amnestic, really doesn't have as many side effects, is quick on, quick off. Important thing to know about etomidate in these patients with head injury is myoclonus. I've had a few times where the CT scan group thought that the patient was having a seizure, so just being prepared that there might be some myoclonus. Onset is very rapid, offset is not as rapid as propofol, but reasonable. And this is a drug that we'd like to avoid if we're thinking about something like sepsis, might affect the adrenal axis, but really something that is more in a prolonged history of sepsis, not in a minor head injury or fall like we're mentioning here. So when and how are you going to make a decision to discharge a patient? I think return to baseline is very different than return to baseline respiratory status. And I think the most challenging time for this is the middle of the night. So many times our patients are waiting for imaging after their injury in the afternoon. By the time the imaging happens and the specialists are able to come from the OR, the family, the patient, and I am all very tired. So after giving the sedative, oftentimes that patient might not return to their normal baseline and be running around the department. But if they're back to their baseline respiratory status, they seem to be able to have adequate hydration prior, even though they've been MPO now. We might want to have them drink something. You have a responsible parent or guardian. They may have a level of consciousness that's below what their baseline is or what they came in, but in the context of this being an overnight, if you give good discharge instructions, and then importantly, make some informed decisions about pain, because I do have many of these patients that might come back if they haven't received adequate pain control as the ketamine wears off. So there's not a perfect answer here, but I would say waiting till the patient is walking and acting at baseline, which some of the guidelines say might lead to quite a long duration of stay in your department. So I've taken you through a brief journey here, hopefully distinguishing sedation from analgesia and when you want one versus when you want both. Talked a little bit about the mechanism of action for some of these agents, both the time of onset and offset, as well as the side effects, and then describing some approaches to choosing either pharmacologic or non-pharmacologic methods for sedation. And with that, I guess I'll take questions at the very end. Thank you.